Assalamu alaikum wa rahmatullahi wa barakatuh. Today we will speak about new subject of pediatric surgery made easy. It is very important for all pediatric surgeon and pediatrician related to Meckel Diverticulum, which may present by abdominal emergency, intestinal obstruction, or gastrointestinal bleeding. Let's start. Meckel Diverticulum. Very important topic for all pediatric surgeon and also pediatrician may present with acute abdominal presentation, and all pediatric surgeon should be aware about Meckel incidence, presentation, diagnosis, and management. By the end of this presentation, you should be able to know what is vitellointestinal duct and its remnant, what is Meckel's diverticulum, what is the clinical manifestation of this diverticulum, and also how to diagnose and how to treat children with symptomatic or asymptomatic Meckel diverticulum. Number one, the first question is, what is omphalomesenteric or vitellointestinal duct? During the fourth week of the gestation, there is a communication between the primitive yolk sac and the developing midgut. This communication is called omphalomesenteric or vitellointestinal, or sometimes vitelline duct. It's very important. These communications allow for the development of the midgut by the pressure in the yolk sac until opening of the oropharyngeal and cloacal membrane. So this duct function as an important for the pressure between the yolk sac and the developing midgut to allow for the growth of the intestinal loops and development until the opening of the oropharyngeal membrane above and the cloacal membrane below. Also, it's very important for the protection of the umbilical vessels during this stage. So by the fourth week of fetal life or gestation, this communication is present between the primitive yolk sac and the midgut loop. The other names is omphalomesenteric, vitellointestinal, and vitelline duct. At the 6th week of gestation of the fetal life, all structures, the yolk sac and the duct and the vitelline arteries supplying the duct, all disappear and become at first rudimentary, then disappear. If they persist, if this duct remnant persists, they may cause many problems. Failure of this regression creates spectrum of anomalies of omphalomesenteric duct remnant or vitelline duct remnant. These anomalies can present clinically in the newborn period, infancy, or maybe later childhood years. It's very important. What are about this remnant? What are the omphalomesenteric duct or vitellointestinal duct anomalies? They may form Meckel diverticulum, which is the most frequent, or umbilical fistula, umbilical cyst, umbilical polyp, or fibrous band. So this is the remnant of the omphalomesenteric duct. What is omphalomesenteric duct? Embryonic duct connecting between the primitive yolk sac and the developing midgut. What is its function? It functions in the intrauterine for the pressure change from the yolk sac transmitted to the midgut. This is number one, allowing for the development of the midgut until the oropharyngeal and cloacal membrane open. Number two, it's a site of the physiological hernia, the intestinal content enlarge and rotate herniate inside the umbilical cord, and then return. The first abnormality or the first remnant is what is called Meckel Diverticulum. What is the Meckel Diverticulum? It is persistent of the intestinal part. This duct communicates between the mid-gut loop, represented by the ileum, to the umbilicus here. Normally, it disappears completely between the 6th to the 10th week. Disappear completely. If the intestinal segment persists, this is called Meckel Diverticulum, persistent of the intestinal part of the omphalomesenteric duct remnant with or without fibrous cord attached to the umbilicus. In some cases, there is fibrous cord from the tip of the Meckel Diverticulum to the umbilicus. So there is a persistence of the part of the duct related to the intestine, called the intestinal part. One should ask, what is the problem? It is a part of the intestine. This is the mid-gut loop, and this is protrusion or bulge or diverticulum. What is the problem? The problem is that this protrusion or Meckel may contain ectopic gastric tissue. Ectopic gastric tissue, yes, secreting HCl. HCl in the ileum, yes. And the mucosa in the ileum, not designed to compensate for HCl. So HCl in this abnormal site may produce ulcer in the ileum, presented with bleeding. This is number one. Number two, this diverticulum, due to ulceration and presence of the HCl or obstruction by the feculus, obstruction like the appendix, may present with diverticular inflammation. Or this diverticulum and the related band may cause the intestine to be either trapped below the band or rotate volvulus intussusception. So this small diverticulum carries significant importance for pediatric surgery. May present with bleeding from ectopic tissue, may present with intestinal obstruction, and also may cause and present with acute abdomen, diverticular inflammation. So it's very important to know that is this a remnant of the intestinal segment or intestinal part of the omphalomesenteric duct, which is a duct intrauterine connecting the hip sac to the mid-gut and usually disappear completely. Number two, umbilical fistula. It's an completely patent vitellointestinal duct with umbilical fistula. Fistula at the umbilicus connecting to the ileum, discharging intestinal content. So this is complete persistence of the tract or of the duct. In Meckel, only the intestinal segment present and this part obliterated. There is maybe fibrous cord or not. Here, umbilical fistula connected the ileal segment of the small intestine to the anterior abdominal wall, as it is obvious in the image. Number three, what's called omphalomesenteric cyst. There is obliteration of the intestinal end and obliteration of the umbilical end with cyst inside. Segment in the mid portion of the duct remain patent. Maybe umbilical polyp. Bright red nodule may contain ectopic gastrointestinal tissue, may be present in the umbilical temple, may contain tiny fragment of the intestinal and the gastric mucosa, and the more common differential diagnosis for the pediatric surgeon is umbilical granuloma. Also, the anomaly may be related to the presence of fibrous cord. Fibrous cord without diverticulum or cyst, just fibrous cord connecting the mid-gut loop or the ileum to the umbilicus. This is a fibrous cord. Persistent cord, the duct obliterate, but it's not fully resorbed, leaving this fibrous cord, or sometimes with persistent vitelline artery. So this duct is very important. It connects the primitive yolk sac to the mid-gut loop. At the 4th week of gestation, usually it obliterates completely and disappear. If they persist, only intestinal part may persist present with Meckel Diverticulum. It is a true diverticulum, true protrusion in the wall of the ileum, formed of all layers of the ileum. What is the problem of this diverticulum? The problem here is it contains ectopic tissue, contains gastric tissue. Ectopic gastric mucosa secreting HCl may produce an ulcer with bleeding, inflammation, obstruction. Moreover, this diverticulum may attach it with a band to the umbilicus. So the intestinal loop may go and trap below this band, or the intestinal loop may rotate and twist around the band. Volvulus, intussusception, intestinal obstruction, bleeding, diverticular inflammation, all related to this diverticulum, or maybe asymptomatic, no presentation. Number 2, maybe complete patency and persistence of the omphalomesenteric or vitellointestinal duct, leading to the child born with umbilical fistula. Fistula of the umbilical connecting with the ileum. Maybe cyst if the mid portion of the duct remain patent and corresponding end obliterate. Maybe fibrous cord connecting the umbilicus to the mid-gut lobe or to the ileum with persistent vitelline artery or not. Maybe umbilical polyp, sometimes differentiated from umbilical granuloma. So at first, you must understand the development and the embryology of the vitellointestinal or omphalomesenteric duct and its related anomalies, related remnant. It's very important to understand this point very clearly. Then we will speak in details about Meckel. What is Meckel diverticulum? It is a protrusion and persistent of the intestinal segment of the omphalomesenteric or vitellointestinal duct. Most common anomaly present in the clinical practice, accounting for about 90% of cases, usually contain abnormal gastric mucosa, and this is the cause of many problems presented with this diverticulum. It results from, yes, patency of the intestinal segment of the duct with or without fibrous band attached from the tip of the diverticulum to the umbilicus. It is a true diverticulum. What's meaning by true? Consists of all normal layers of the bowel, not false, not cyst. It is a true diverticulum. Patient with other gastrointestinal malformation, as esophageal atresia, imperforate anus, and omphalocele may have increased risk of the Meckel diverticulum. However, no reported familial predisposition. What are the clinical symptoms and complications? As we said, maybe gastrointestinal bleeding. HCl in the diverticulum produce ulceration of the nearby ileal mucosa. So there is bleeding. Small bowel obstruction. Yes, may be related to intussusception. This Meckel act as a lead point, may get inverted inside the lumen of the ileum, and we will speak about this. Or may be related to the presence of internal hernia, or may be related to volvulus around this band. Inflammation, acute Meckel diverticulitis may be very similar to acute appendicitis. And clinically, it may be very difficult to differentiate both conditions. Neoplasia, very rare that neoplasm may arise in the Meckel diverticulum. And this is reported. Many papers speak about this in elderly. Lifetime risk of developing complication from Meckel diverticulum is about 6.4, possibly higher in male versus female. The question now, What is the incidence of the Meckel Diverticulum? Is it common? To take this important, this is very rare. The true incidence is unknown, as most children are asymptomatic. So true incidence is unknown. However, incidence typically is at about 2%. However, some review of autopsy studies found the incidence of 1.2%. 4% of the patient will become symptomatic with risk of developing symptom decrease with age. Incidence may be increased in the patient with major anomalies of the umbilicus, alimentary tract, nervous system, or cardiovascular system. So, pediatric surgeon may be faced with baby with alimentary tract anomalies, umbilical anomalies, phallocele, and nervous system or cardiovascular associated with Meckel diverticulum. Recent report found that 53% of Meckel diverticulectomies are performed before 4 years of age, and that male to female ratio is about 2.3 to 1 overall and 3 to 1 in symptomatic patients. Now, there is a rule called Rule of Two regarding Meckel diverticulum. What is this rule? Number one, it affects 2% of the population. 2 to 1 male to female ratio, usually discovered by the 2 years of age, located 2 feet from the ileocecal valve, commonly 2 cm in diameter, 2-inch long, contain 2 types of the ectopic mucosa, gastric, which is the commonest, followed by the pancreas. So for remembering data about Meckel's, it's always possible useful to remember this rule of two regarding Meckel diverticulum. What is the clinical presentation of Meckel diverticulum? Number one, a variety of symptoms can develop depending on configuration of the duct remnant. Isolated Meckel, Meckel with a band, Meckel containing ectopic gastric mucosa, and the presence of the ectopic mucosa. So the configuration and the presence of the ectopic mucosa will determine the presentation of the child. However, the 3 most common presentations are: number 1, gastrointestinal bleeding; number 2, small intestinal obstruction; number 3, diverticular inflammation, acute diverticulitis, acute Meckel diverticulitis, and acute abdomen. Other less common signs include maybe cystic abdominal mass, maybe umbilical fistula, if there is complete patent duct, maybe letter hernia, Meckel diverticulum incarcerated in the hernia, which may be inguinal, femoral, or umbilical hernia. Neonatal presentation of the Meckel diverticulum is uncommon, usually due to perforation or obstruction. In adults, yes, there is reported cases of neoplasia that can develop within the Meckel, the carcinoid, and the neuroendocrine tumor. Also, other tumors like adenocarcinoma, leiomyosarcoma, and gastrointestinal stromal tumor, GEST tumor, and lymphoma may arise from Meckel, especially in elderly. We will speak about the first presentation, which is bleeding Meckel diverticulum. Most common complication of the Meckel diverticulum and account for nearly about 50% of all lower gastrointestinal bleeding in children. Serious problem. All pediatric surgeon and pediatrician must be aware of this problem. Bleeding Meckel diverticulum. Classic presentation is painless rectal bleeding in a young child. Very important. Bleeding Meckel may manifest clinically as melena, dark stool, or hematochezia, fresh red blood per rectum. And in case of chronic bleeding, the patient may have anemia. Repeated and continuous bleeding may lead to hemorrhagic shock. So it's very important to consider this as a significant cause of lower gastrointestinal bleeding in children. What is the cause of the bleeding? As we said, presence of ectopic mucosa, gastric mucosa present in the Meckel Diverticulum that bleed. This gastric mucosa will produce gastric acid, HCl, which cause or lead to mucosal ulceration. Ulcer may occur in the junction between the ectopic and the normal mucosa, in the normal ileal mucosa, or maybe sometimes within the ectopic mucosa itself, or on the mesenteric side of the normal ileum. So there is ulceration and bleeding related to the presence of ectopic mucosa. Helicobacter is associated with many ulcers in the duodenum and stomach. Yes, it is reported. However, studies showing that Helicobacter rarely present in the bleeding vector. Rarely present. So the main cause is ulceration of the normal ileal mucosa due to presence of ectopic HCl released from ectopic gastric mucosa. How to diagnose bleeding Meckel Diverticulum? Very essential and very important for all pediatric surgeon and pediatrician to understand how to diagnose. Number one, complete history and physical examination can help the pediatric surgeon to exclude some potential bleeding sources. Number two, placement of the nasogastric tube can exclude the presence of the upper gastrointestinal tract source for this bleeding. Number three, imaging studies. Very essential. Technetium 99 per technitate study or called Meckel scan, which is a preferred radiological test. And other tests useful in the evaluation of the intestinal bleeding, we'll speak about it. Also, some other modalities not used regularly but may be helpful when all other tests have failed to identify the site of the bleeding. So you deal with the case of the lower gastrointestinal bleeding in a child. You must put the differential diagnosis. You should follow a systematic approach trying to identify that this bleeding may be related to complicated Meckel Diverticulum. By history and physical examination, usually the history and physical examination is unremarkable. Bleeding usually perfuse and painless, manifest as a bright red blood per rectum with blood clots. Rarely the bleeding may be occult bleeding for weeks, months, with the patient presenting with chronic anemia. And many children require blood transfusion, although life-threatening hemorrhage is rare. So bleeding usually perfuse, painless in a young child. Chronic and intermittent bleeding may be reported, and the child in such cases present with chronic anemia, and many children reported to have repeated transfusion. So any child present with hemoglobin positive stool by stool analysis with chronic anemia should be evaluated for Meckel Diverticulum. So it's very important to put Meckel Diverticulum for the differential diagnosis of the lower gastrointestinal bleeding in children. Imaging studies can often determine the etiology or the source of the bleeding. In addition to Meckel, the differential diagnosis of the lower gastrointestinal bleeding may include anal fissure, intestinal polyp, inflammatory bowel disease, intestinal duplications, hemangiomas, arteriovenous malformation. It's the rule for the pediatric surgeon and pediatrician and the team involved to search for the cause of the bleeding, lower gastrointestinal bleeding. So Meckel may be sometimes difficult for diagnosis. by the criteria of the bleeding, right, massive, painless bleeding in a young child, may be occult, yes, be present with features of chronic anemia. The important test is technetium 99 pertechnetate scintigraphy, or called Meckel scan. The idea for this test is based on when we inject technetium intravenous, it will be taken up and secreted by the gastric mucosa. Yes, by the normal gastric mucosa and by the ectopic gastric mucosa, as we see in this image. This is the Meckel. You will see that there is focal accumulation of this tracer in the Meckel, in the right lower quadrant. And this is the gastric uptake, normal uptake by the gastric mucosa. And this is the urinary bladder excreting the tracer. So the study based on the idea or the fact that most bleeding Meckel contain ectopic gastric mucosa. So intravenous injected technetium pertechnetate is taken up and secreted by the cells of the gastric mucosa, by the normal gastric mucosa and by the ectopic gastric mucosa present in the Meckel. So this will be appear on the scintigraphy. So scintigraphy can visualize this accumulation in the Meckel diverticulum, and also the bladder will be obvious due to excretion of the dye. Sometimes it's very difficult because Meckel don't contain ectopic gastric mucosa, so the test may be negative. Sometimes the Meckel is lying down behind the bladder and obstructed, and we cannot see this picture. Active bleeding is not required because the test depends on the fact that we search for the presence of the ectopic gastric mucosa, not for the bleeding. Technetium here is searching for the presence of the ectopic gastric mucosa. So active bleeding is not required for positive results, unlike angiography or tagged red blood cell scan. This is other modalities used for the diagnosis of lower gastrointestinal bleeding. False negative results. Meaning by the false negative means wrong negative. So the diverticulum, if the diverticulum doesn't contain gastric mucosa, other types will not take that radiotracer. So will be negative test. The diverticulum lying low in the pelvis and obstructed by the bladder sometimes not appear. So the test may be false negative or wrong negative, means that the diverticulum is present, however, may not contain ectopic mucosa, or sometimes may be present low in the pelvis obstructed by the bladder. False positive means wrong positive. Yes, can occur also as a result of intestinal duplication containing ectopic gastric mucosa, as we said in the previous presentation, bowel obstruction or inflammation, intussusception, arteriovenous malformation, ulcers, and some neoplasm may give false positive results and affect the accuracy of the study. Sometimes we can use uptake enhancement with the use of the pentagastrin or histamine 2 blocker may improve the accuracy of the study. However, some authors propose that the potential for the false negative raise some concern about its use. Although the positive predictive value of the scintigraphy is near 100% and the specificity is over 95, the sensitivity has been reported to very low as 60% with negative predictive value of 75. However, recent series reported sensitivity of about 89 to 100% in children presenting with intestinal bleeding symptoms. So it's very important to understand these statistics related to the predictive value, sensitivity, and specificity of the study. Because negative scan does not exclude the possibility of the Meckel. As we says, there is maybe Meckel don't contain ectopic gastric mucosa. There is maybe Meckel lying down in the pelvis, obstructed by the bladder. So several authors and pediatric surgeons recommend diagnostic laparoscopy for definitive evaluation, especially in the cases with anemia and high clinical suspicion for bleeding diverticulum. So if the clinical data focus on that there is maybe bleeding diverticulum, child presented with anemia, with occult blood, repeated bleeding, blood transfusion, in such cases with a negative technetium per technetate scan, you can perform diagnostic laparoscopy as recommended by many pediatric surgeons. Other tests for the evaluation of the intestinal bleeding is well known, is a mesenteric angiography. We can perform selective catheterization of the superior mesenteric artery to identify the presence of the ectopic gastric mucosa. However, it is an invasive test. Number two, it limited to acute hemorrhage, require active bleeding of at least 0.5 milli per minute. So to use mesenteric angiography, you need active bleeding of at least 0.5 milli per minute, unlike the technetium. In the scintigraphy by the technetium, you will search for the ectopic mucosa. You don't require the presence of active bleeding. Number three, omphallomesenteric or vitelline artery supplying the Meckel diverticulum can be identified with mesenteric angiography. Technetium tagged red cell scan require bleeding also of at least 0.1 milli per minute. More sensitive, but less specific for localizing bleeding source. So the only test can be used without active bleeding is technetium per technetate. Ultrasound and CT, usually acute bleeding may not be detected with the use of the ultrasound or CT. However, secondary signs of the thickening and enhancement of the wall of the diverticulum thickening may be present in a case of very low flow bleeding, intermittent bleeding, as we see in this image. There is maybe thickening of the wall, there is maybe enhancement by the ultrasound and CT. So the most important of the imaging is technetium 99 per technetate scan, or called Meckel scan. Meckel scan can detect the presence of ectopic gastric mucosa. It should be the preferred radiological test, followed by the scintigraphy. You will see accumulation of this radio tracer in the right lower quadrant, pointing to the presence of the ectopic mucosa, plus the presence of the normal gastric mucosa in the stomach. Don't require active bleeding or acute bleeding, however, may be miss Meckel in a case of absence of the ectopic gastric mucosa, presence of the pancreatic or other types. Number two, if the Meckel is lying very down or low down in the pelvis, obstructed by the bladder. In such case, if you suspect that the bleeding may be related to the Meckel, you should perform diagnostic laparoscopy. Other modalities not used regularly but may be helpful when other tests fail is upper and lower endoscopy. However, they will not allow visualization of the Meckel, but they are helpful to evaluate other disorders that may produce rectal bleeding. So upper endoscopy will diagnose upper causes for the bleeding. Lower endoscopy will diagnose other sources for the bleeding. However, Meckel will not be seen with upper or lower endoscopy. Wireless capsule endoscopy and the double balloon enteroscopy techniques is a very recent and very qualified very sophisticated investigation have been utilized to identify Meckel Diverticulum. So this is other modalities. So you can diagnose with a history and examination, difficult, but depend on the brightness, burnless rectal bleeding in a young child, maybe occult bleeding, maybe repeated blood transfusion, usually insertion of the nasogastric tube to identify upper gastrointestinal bleeding sources. Imaging very important, and to put the differential diagnosis, the technetium is very important, followed by other tests, enteric angiography, tagged red blood cells, and other modalities, upper and lower wireless capsule endoscopy. The second presentation of the Meckel is a small bowel obstruction. Small bowel obstruction, yes. The Meckel can cause intestinal obstruction through several mechanisms. Number one, intussusception. Yes, intussusception. Meckel diverticulum may get inverted inside the ileal lumen and act as a lead point, as we explained in the presentation of intussusception. So you can imagine that the Meckel is a protrusion in the wall of the ileum, outside protrusion, get inverted and become inside protrusion and stimulate the peristalsis, so the peristalsis will act with this Meckel as a lead point and lead to telescoping of the proximal bowel into the distal. May become inverted, extending into the ileal lumen, act as a lead point for ilioileal, this is at first, followed by ileocolic intussusception. So the problem at first started by the ileum into ileum, ilioileal, followed by this intussuscepted ileum will pass into the ascending colon, ileocolic intussusception. This is number one. Intestinal obstruction mechanism. The first one is intussusception. Number two, volvulus. Yes, if the Meckel diverticulum attached by the band to the umbilicus, the small bowel or the ileum may become twisted or kink around this vitelline remnant with a fibrous cord between the diverticula and the umbilicus, presented with volvulus. Clinically, intestinal obstruction, abdominal distension, vomiting, obstipation, abdominal pain, obstruction, small bowel obstruction in a child, may be related to intussusception, inverted inside, act as a lead point, or may be volvulus. The ileum will kink or twist around the vitelline remnant attached from the Meckel to the umbilicus. Maybe internal hernia. Yes, due to this band. This band called the mesodiverticular artery band. Meso related to the mesentery and diverticular related to the diverticulum, coursing from the base of the mesentery to the diverticulum, under which the small bowel become trapped and incarcerated. So below or under this abnormal mesodiverticular band, the small bowel may get trapped and internal hernia produce bowel obstruction. This is obstruction with intestinal small bowel obstruction, distension, vomiting, and obstipation. So this is the third mechanism. Maybe intussusception, inverted Meckel act as a lead point, maybe volvulus around the present remnant, maybe internal hernia, herniation of the intestine inside the abdomen below this abnormal band called meso, related to the base of the mesentery, diverticular, related to the Meckel diverticulum. So the name is formed of two parts, mesodiverticular band containing mesodiverticular abnormal vessels. The other rare obstructing mechanism is what's called incarcerated Litter's hernia. What is Litter's hernia? It's a hernia containing Meckel diverticulum. So the Meckel may become entrapped inside inguinal, femoral hernia, or sometimes other types of hernia, become entrapped inside the sac and cause incarcerated hernia. Sometimes very long or giant diverticulum may kink or rotate around its base, producing intestinal obstruction. So small bowel obstruction mechanism related to the presence of the Meckel is very important for the pediatric surgeon to be fully understood. Maybe intussusception. How can you imagine intussusception? Yes, this outside or finger-like protrusion become inverted inside the new and act as a lead point, leading to at first ilioileal intussusception, followed by the iliocopic. This is number one. Number two, there is maybe abnormal band, mesodiverticular band containing abnormal anomalous vessels. So the intestinal loop may be trapped below the band, leading to internal hernia. There is maybe volvulus twisting, kinking of the ileum around the abnormal duct remnant. There is maybe incarcerated Litter's hernia or long or giant diverticulum that twist. So the Meckel may cause significant gastrointestinal bleeding, may cause small bowel obstruction, major problem. How to diagnose the Meckel as a cause of a small intestinal obstruction? Very important question for all pediatric surgeon and pediatrician. How we can know or diagnose that this child with small bowel obstruction, the cause is Meckel. How you can diagnose? Small bowel obstruction, distension, vomiting, obstipation, or constipation. Many causes may cause bowel obstruction, small bowel obstruction in many children. How you can suspect or diagnose? Is it possible preoperative? Or the case will be diagnosed intraoperative? So the diagnosis is not usually definitively determined preoperatively. This is the rule. In many cases, you cannot judge preoperatively that the cause of this small bowel obstruction is complicated Meckel diverticulum. However, should be strongly considered as the etiology or the cause of the small bowel obstruction in a child more than 5 years of age, not undergone any abdominal operation, and present with signs and symptoms of a small bowel obstruction. So the pediatric surgeon should suspect Meckel as the cause of obstruction in any child more than 5 years, not undergone previous abdominal surgery, there is no adhesion, no band, present with signs and symptoms of the small bowel obstruction. The clinical presentation will be the same. Typical signs of intestinal obstruction, any obstruction, acute abdominal pain, bilious vomiting, obstipation, yes. In case of intussusception, if the Meckel causing intussusception, inverted and acting at the lid side, at the lid point, as we discussed previously in the presentation of intussusception, plus manifestation of intestinal or bowel obstruction, will be the child may pass current jelly stool. On physical examination, may demonstrate palpable abdominal mass, sausage-shaped abdominal mass. If volvulus happen and progress to ischemia, the child will develop signs of peritonitis and may present with acute abdomen, may present with rigidity, tenderness, and extreme presentation. So this is related to the etiology of the obstruction, special presentation related to the etiology. Imaging studies. We can use ultrasound, yes. We can use color Doppler, demonstrate anomalous vessels, mesodiverticular artery. We can use CT or air enema. However, if the clinical suspicion is with a bowel obstruction for the safety of the child, and if this investigation may lead to lose time, you can go to diagnostic laparoscopy to diagnose the case and proceed accordingly. In intussusception, the diagnosis is confirmed by the ultrasound or air enema, but rarely identify pathological lead point at the Meckel. Very difficult for the ultrasonographist to identify that the cause is Meckel. Ultrasound may diagnose that the obstruction related to intussusception. Air enema, yes, in intussusception may reduce the ileocolic portion of the intussusception, but often the ileoileal component is not successfully reduced. And if reduced, symptoms will often recur. So, if the case is intestinal obstruction due to intussusception, diagnosis usually confirmed by the ultrasound. We discussed this. Ultrasound will diagnose what's called target sign. Or if you diagnose or suspect by ultrasound intussusception, clinically recurrent jelly stool, you feel abdominal mass, you can proceed to air reduction enema. Air reduction enema, yes, may reduce the ileocolic part. As we said, that the intussusception in a case of Meckel start at first at the ileoileal, then progressed to the ileocolic. So when we perform enema, the ileocolic will reduce first, and the ileoileal may be difficult to reduce, and if reduced, often recur. Meckel diverticulum will be discovered either intraoperative once reduced completely the intussusception or upon examination of the resected segment of the intestine. So usually Meckels cannot be detected preoperatively with ultrasound. Ultrasound will only diagnose the case as intussusception, the clinical presentation. And if you proceed to perform an air reduction enema, you will reduce the first part, second part may be difficult or may recur after reduction. Meckel diverticulum as a cause specific will be diagnosed intraoperative once you reduce the intussuscepted mass, and also if you resect when you examine the resected part of the intestine. Ultrasound may show in intussusception also the donut sign, target sign, or bull's eye sign, which is typical of ileoileal intussusception. This is moderate dilatation of the small bowel, and this is the bull's eye sign, the eyes like the eye of the bull. Donuts are called sometimes donuts or target sign. Inverted diverticulum, like this ultrasound presentation, is inverted into the lumen of the distal small bowel, indicating that the diverticulum is acting at the lead point of this ileoileal intussusception. However, sometimes it's very difficult to be demonstrated. This is inverted diverticulum inside the lumen of the intestine. The CT may show the inverted Meckel diverticulum as intraluminal mass with central hypoattenuating content representing the entrapped perienteric fat tissue surrounded by peripheral enhancing soft tissue component that represent the diverticular wall. This is very sophisticated and advanced data related to the use of the ultrasound and CT, trying to identify the Meckel as the cause of intussusception. However, in most cases, the cause is diagnosed intraoperative. In volvulus, if there is a band causing intestinal obstruction by twist or volvulus, the pattern of the obstructions with multiple fluid-filled dilated intestinal loop, like this. Part of the intestine called closed loop obstruction, dilated filled intestinal loop. Severely dilated closed small bowel loop filled with fluid, like this picture in the ultrasound. Also in the CT, the same dilatation as we see of the bowel loop, dilatation of the bowel loop proximal to the transitional point with some degree twisting of the mesenteric and mesenteric vessels. Meckel diverticulum itself may not be seen as the CT, and the diagnosis usually confirmed at surgery. Can imagine this the same as the ultrasound, closed loop, dilated bowel segment with a fluid inside. So the ultrasound and the CT in the volvulus may be helpful. However, diagnosis of the Meckel is usually performed at surgery. A recent report interestingly showed complicated Meckel diverticulum presented with intestinal obstruction with schistosoma parasite harboring within the diverticulum. This is a recent report published very recently that at certain center that CT may show complicated Meckel presenting with intestinal obstruction, and there is a schistosoma parasite inside the diverticulum. The third presentation is Meckel diverticulitis. So the first one is bleeding, Meckel Diverticulum, and how to diagnose. What's the clinical presentation? The second one is intestinal obstruction, small bowel obstruction. What is the causes for the bowel obstruction in Meckel? How to diagnose. The third part is Meckel diverticulitis, inflammation of the diverticulum, like acute appendicitis. Inflammation representing about 10 to 20% of cases of the symptomatic Meckels, more frequent in young children. There is inflammation of the Meckels. This is the vitelline vessels supplying the Meckel diverticulum. Inflammation often attributed to the presence also of the ectopic gastric or pancreatic tissue, obstruction of the diverticular lumen, like the mechanism for acute appendicitis, stasis of the enteric content within the diverticulum, presence of the enterolice or foreign body, sometimes parasitic infestation. This is intraoperative photo showing inflamed Meckel diverticulum. So presenting clinically like acute abdomen, like acute appendicitis. How to diagnose Meckel diverticulitis? Very important question. How to diagnose? Number one, by the clinical presentation. Is it possible? Meckel diverticulitis is often misdiagnosed as acute appendicitis due to similar presenting symptoms, including the periumbilical pain that may be associated with nausea, vomiting, and fever. However, the point of maximum tenderness on the physical examination may migrate within the abdomen. May migrate, not at the McBurney point exactly, may migrate sometimes inside the abdomen. This is maybe a little different. Meckel diverticulitis can also present with perforation, like appendicitis, yes, peritonitis, intra-abdominal abscess formation, obstructive signs and symptoms. So the diverticulitis itself may perforate, may form an abscess, may present with intestinal obstruction. The possibility of the misdiagnosis is very high. So the intraoperative finding of the normal appendix in a child suspected of having appendicitis should lead to careful search for the Meckel diverticulum. This is the rule. If you diagnose a case of an acute appendicitis and you go to the OR after exploration or performing diagnostic laparoscopy, the appendix is looking normal. You should search for the Meckel. Due to variability of the location of the diverticulum, at least 5 feet of the distal small bowel should be examined, starting from the terminal ileum and working proximally. Start from the ileocecal at the terminal ileum and go up, go proximal, searching for the presence of the diverticulum, inflamed diverticulitis. In some cases, preoperative CT or ultrasound may find inflamed midline mass with normal appendix, suggesting the correct diagnosis. Sometimes there is an inflamed blind-ended structures in the midline, may be inflamed Meckel diverticulum in the preoperative ultrasound or CT. Unlike the presentation of the appendix by the ultrasound and CT, the appendix is long structures, inflamed, related to the right iliac fossa, related to the cecum. So if the ultrasound CT diagnose inflamed midline structures, this should be suspected as a Meckel diverticulum. Ultrasound, the spectrum of appearance of acute diverticulitis, fluid-filled, blind-ending pouch. Acute diverticulitis, usually fixed, non-compressible, located in the right iliac fossa with inflammatory change of the surrounding effect. So ultrasound may show fluid-filled blind bowel with gut signature. What's meaning by gut signature? We mean that the same structures or the same wall of the gut. Blind pouch inflamed in the midline with gut signatures formed of all layers of the bowel. What is this? This is diverticulitis, not related to the side of the appendix. This blind ending pouch can sometimes be confusing, maybe tubular appearance, cystic appearance, another pattern, soft tissue mass with concentric ring that can be mistaken for a small bowel intussusception. So the matter sometimes very difficult. The clinical presentation with acute abdomen, acute presentation, pain like the same to acute appendicitis. Diagnosis with ultrasound and CT. If you're lucky, you can ultrasound, preoperative, and CT may diagnose inflamed midline mass away from the site of the appendix. And with gut signature, with all layers of the bowel, you can suspect that this may be Meckel diverticulitis. If you already go to the OR, searching for perforated appendicitis, and you find the appendix looking normal, you should search for the Meckel, starting from the ileocecal and go proximally. It's very important that preoperative CT and ultrasound may sometimes not detect the presence of Meckel diverticulitis. Meckel perforation, it's extreme of presentation. Diverticulitis and perforate, rare, but life-threatening complication can be secondary to ischemia caused by the small bowel obstruction or due to inflammation and ulceration due to diverticulitis. In the setting of the acute abdominal pain and pneumoperitoneum, at the imaging, the possibility of the perforation should be considered. So you should consider the perforation if there is a pneumoperitoneum, like perforation of other gastrointestinal viscous. As we see, this is small rim of the pneumoperitoneum in the radiograph. However, radiograph has no role in the diagnosis of the Meckel diverticulum. Perforation may be related to Meckel or other parts of the gastrointestinal tract. Further evaluation with ultrasound or CT may be useful unless the patient directly go to surgery, acute abdomen. And in these cases, as we said, sometimes you don't have a time to lose in performing some sophisticated investigation, and you will transfer the child to the OR. So this is extreme, is a perforation of the Meckel. So the Meckel may present with gastrointestinal bleeding, may present with spinal obstruction, may present with diverticulitis, like appendicitis, or may present in the extreme with perforation. So the story of the Meckel is very important for the pediatric surgeon and pediatrician. So this table summarizes the presentation. Maybe bleeding. Ectopic gastric mucosa, yes, really is a hydrochloric acid which causes ulceration of the adjacent ileum. True. Abdominal pain, Meckel diverticulitis. Inflammation causes a clinical feature similar to acute appendicitis. Perforation of the adjacent ileal ulcer may present as inflammatory mass with a pneumoperitoneum and peritonitis. Yes. Obstruction may be by intussusception. Intussusception, the Meckel may invert and act as a lead point for intussusception. This is responsible for about 2% of the intussusception. Obstruction by band. Band may cause twist, or in the case of volvulus, or internal hernia. Band extending from the Meckel to the root of the small bowel mesentery or the umbilicus may cause loop of the bowel to become trapped around it, producing bowel obstruction, and sometimes Meckel may be found as incidental finding, may be found during laparotomy for other conditions like appendicitis, and we will speak about this debate shortly. What to do if you face a case with incidentally detected Meckel diverticulum with no presentation. This is a summary for the complication and some investigation. So there is maybe bleeding, Meckel, maybe obstructions, inflammation, perforation, neoplasm. In a bleeding, scintigraphy is the top. Detection of the gastric mucosa, ultrasound CT may show bowel wall thickening in case very low bleeding and very recurrent bleeding. However, scintigraphy is very essential. In obstruction, X-ray confirm obstruction, but no rule in detecting Meckel's as a cause. There is multiple fluid level obstruction or perforation or pneumoperitoneum. Ultrasound may diagnose intussusception, may be diagnostic and therapeutic. CT may show volvulus. In inflammation, we can use ultrasound CT. Sometimes in perforation, also ultrasound and CT may localize perforation and plan surgery. In neoplasia, ultrasound CT and MR. All this investigation try to diagnose the problem. However, usually they diagnose the case as bleeding, as obstruction, inflammation, perforation, and you cannot diagnose exactly by investigation that the Meckel diverticulum is the cause. So the pediatric surgeon should balance between losing time performing investigation, presentation of the child, suspicion of the bleeding Meckels, suspicion of the child with recurrent bleeding with presentation of Meckel. So you can go to the diagnostic laparoscopy. In a case of acute emergency, you may need to explore and diagnose intraoperative. However, you should understand the complication of the Meckel and the presentation of the Meckel diverticulum. Now, how to treat Meckel diverticulum? Very essential and very important for all pediatric surgeons. How to treat? We should classify the treatment in two major categories. Meckel present with symptomatic Meckel diverticulum. What meaning by symptomatic? Bleeding, obstruction, diverticulitis, perforation, or asymptomatic Meckel. Detected on imaging study, you perform imaging for the child for other cause, and you diagnose, wow, there is a Meckel diverticulum, or detected intraoperative. You are surprised, you're performing other operation or other surgery for the child, wow, there is a Meckel diverticulum. How to take a decision? In a case of symptomatic Meckel diverticulum, there is no debate. The definitive rule is surgical resection, whether to perform open surgery or laparoscopic surgery. So all pediatric surgeons conclude that you need to perform resection of this Meckel as a cause of the bleeding, as a cause of the obstruction, as a cause of the divert inflammation or acute abdomen, as a cause of perforation. So you must resect open or laparoscope. Resection may be in two parts. Maybe just diverticulectomy, remove only the diverticulum, or to perform segment, remove segment of the ileum containing the diverticulum. So you may only remove the diverticulum, called diverticulotomy. Diverticulectomy, yes, remove this diverticulum, or segmental ileal resection with anastomosis. What is the difference? Sometimes, in some cases, removal of the diverticulum will leave behind an ulcer in the ileum. So you need to remove the segment or ileal resection. Let's see. The preoperative preparation should include exactly rehydration with intravenous fluids, correction of the electrolyte abnormalities, antibiotics, gastric decompression of the patient has a bowel obstruction, blood transfusion in case of bleeding with significant anemia. In patient with obstruction or inflammation, intestinal obstruction or inflammation, simple diverticulectomy is often sufficient as long as all ectopic tissue is removed. So we can perform just removal of the diverticulum in case of obstruction or inflammation. If the pediatric surgeon are sure that all ectopic gastric tissue are removed within the diverticulum, you perform an elliptical incision, removing the diverticulum, and close this transverse with stay suture, and then close the transverse. This is one option. So in case of obstruction or inflammation, simple removal of the diverticulum, often sufficient, as long as all ectopic tissue is removed. If the Meckel is discovered after reduction of intussusception, as this picture, this is intussusception, found intraoperative, and after reduction, you may show that the Meckel is the cause. In such cases, you have to perform whether removal of the diverticulum may be possible, to remove the diverticulum only. Although segmental ileal resection may be safer, depending on the appearance of the bowel. Maybe congested bowel, maybe the bowel is in a condition that query for vitality of the bowel. So in such case, to be in the safe side, you may remove the segment of the ileum. So removal of the diverticulum may be an option if there is a case of intussusception. However, depending on the appearance of the bowel, you may need to perform removal of the segment of the bowel, provided that, or as long as all ectopic tissue, pediatric surgeon is sure that all ectopic tissue removed. In case of bleeding, segmental resection is the safest. Yes, to remove the diverticulum and remove the ulcer, not to leave behind bleeding ulcer. You deal with case of bleeding. And most definitive approach is a segmental resection, as the ulcer may present at the base of the diverticulum or on the mesenteric side of the ileum. So you need to perform segmental resection. However, several recent studies reported the success with the diverticulotomy alone, with no episode of recurrent bleeding, with the advantage of shorter operative time and shorter length of hospital stay. Some recent report reported that removal of the diverticulum alone may be okay. However, the safest is a segmental resection. So the removal may be open laparoscopic. The removal may be just the excision of the diverticulum or segmental ileal resection, removing the part of the ileum containing the diverticulum. According to the diagnosis, whether the cause is obstruction, inflammation, bleeding, the pediatric surgeon should judge and choose between the different options, whether to remove the diverticulum only or perform segmental area resection. In one recent study, the site of the ulcer is often within few millimeters of the ectopic mucosa, and removal of the diverticulum were found to be free of the gastric mucosa, the margins. After resection, opening of the specimen can provide confirmation that the ulcer has been removed. Okay. Laparoscopic resection, if you decide to use a laparoscope, yes, now commonly utilized for the resection of the Meckel diverticulum, as it can be both diagnostic and therapeutic. Meckel diverticulum can be resected by two techniques. Intraoperative technique, we mean that perform the procedure inside the abdomen using the laparoscopic instrument, or maybe extracorporeal, removal of the diverticulum or segmental resection. We mean that we enter by the laparoscopy through single incision or multiple incision, and at the step of resection or suturing, we deliver the diverticulum through the umbilicus and performing the sutures and removal outside the abdomen, handmade. This is called laparoscopic assisted or extracorporeal. So we may have an intracorporeal resection, removal, and suturing inside the abdomen. Need an advanced pediatric surgeon, well-trained pediatric surgeon, or may perform helped or assisted technique. The port site will be the same as for the laparoscopic appendectomy, umbilical port and two left lower quadrant port to manipulate according to the patient age and the abdomen size to remove the diverticulum. Laparoscopic assisted part inside and part outside is generally preferred in infant and small children due to limited intra-abdominal working space, which make the use of the stapler sometimes difficult. Segmental resection is also more easily achieved extracorporeal. So it's very easy for the pediatric surgeon to perform the procedure even with single incision just at the umbilicus, and you diagnose, you grasp the diverticulum outside from the umbilical incision and perform the resection and stomosis and return the ileal inside. Due to limited space to work inside the abdomen of the small infant and children, so it may be suggested by some pediatric surgeons, it may be better for the manipulation and work of the pediatric surgeon. Extracorporeal, running of the bowel, and removal of the diverticulum, segmental resection if needed, can also be completed with single incision laparoscopic approach as well, as we said. So this is the first part of the treatment. Treatment of what? Treatment of symptomatic Meckel diverticulum, presented with bowel obstruction, diverticulitis, present with intestinal obstruction. Surgical resection, no debate. Surgical resection, open or laparoscopic? Yes. surgical resection, open or laparoscope, maybe removal of the diverticulum only, or removal of the part of the ileum with the diverticulum. And the choice will be between these two parts. Management of asymptomatic, incidentally found Meckel diverticulum. This is a debate and challenging for the pediatric surgeon. Resect or not, or leave the diverticulum, remain a controversial. So the management of asymptomatic incidentally found Meckel diverticulum, to resect or not, remain a controversial. When Meckel diverticulum is found incidentally on imaging studies, the operative intervention is not indicated for asymptomatic diverticulum discovered on the imaging. So when you perform an imaging, ultrasound, CT, and you found incidentally the Meckel diverticulum, intervention is not indicated to remove this diverticulum. The most important, when Meckel diverticulum is found incidentally intraoperative, you perform surgery for other pathology, other diagnosis, and surprisingly, you find Meckel diverticulum asymptomatic and incidentally detected. There is many schools in this problem. Several studies recommend resection, remove the Meckel. Incidentally detected, yes. No symptoms, yes. They arguing that risk of the future complication or malignancy and low risk from resection. You have risk of further future complications. This Meckel may become inflamed, may cause bowel obstruction. These Meckels may lead to diverticulitis. And there is low risk from removal. Remove the Meckels and simple operation in the elective setting. Number two, they are arguing that Meckel diverticulotomy is not associated with added morbidity or mortality, and that morbidity and mortality after surgery for complicated diverticulitis, if you don't resect and this Meckel get infected and complicated, may seen in up to 12% of cases, which is 10% higher to incidental diverticulotomy. So they weight the benefit and risk from removal versus leaving the diverticulum. So the first school of pediatric surgeon recommend resection for incidentally detected intraoperative Meckel. Resect. They arguing that the risk of the future complication or malignancy and the risk of the complication is low, and low risk of the complication from resection. High risk of complications from malignancy or other complication, and low risk from resection. Number two, they arguing that the removal of the diverticulum not associated with added morbidity and mortality. On the other hand, the complicated diverticulitis may be 12%, which is 10% higher than incidental removal of the diverticulum. This is the first school to recommend resection. On the other hand, no, there is a several also neoplasms. The third reason for removal is a several neoplasm reporting arising in the Meckel diverticulum. You said that the neoplasm is very rare, yes, and may occur in elderly, yes. However, they arguing that serious neoplasm, like gastrointestinal stromal tumors, spinal adenocarcinoma, although extremely rare, they arguing that there is maybe a benefit of resection in asymptomatic patient with a strong cancer family history. So in such cases with a strong cancer family history, this may deserve some special consideration. So remove the diverticulum incidentally found intraoperative. The first school of pediatric surgery recommend resection. They arguing that the risk of complication, future complication may be higher than the risk of removal. This is number one. Number two, the morbidity and mortality from removal is less than the morbidity and mortality from removal of complicated diverticulum. Number three, several neoplasms reported in the Meckel, carcinoid, GIST, intestinal adenocarcinoma, although these tumors reported very rare and in adult. However, they put that if you face with a case with a strong cancer family history, in such cases, you may need special or some special consideration related to the development of cancer in this Meckel if you leave it inside the abdomen. Other studies or other school or other pediatric surgeon recommend no resection for incidentally detected asymptomatic Meckel diverticulum, arguing that the risk of the future complication is less than the risk of the surgical resection, opposed to the previous opinion. Number two, no definitive evidence to support incidental resection as unplanned diverticulotomy was noted to have higher post-operative complication, and that about 755 patients would require incidentally detected Meckel diverticulotomy to be resected to prevent single fatality. So to prevent single deaths, in some study, they removed 758 cases of the Meckel diverticulum. So this school recommend no resection. Don't resect incidentally detected Meckel diverticulum, because they argue that the risk of the future complication is less than the risk of the resection. Number two, they suppose that no definitive evidence present in the literature to support incidental resection as unplanned diverticulotomy or removal of the diverticulum was noted to have higher post-operative complication. Third school recommend selective approach between resect, no resect. There is a selective one, depending on the Meckel diverticulum characteristic. So they said, for the pediatric surgeon, please look for the characteristic of the diverticulum. They recommend removal of all incidentally detected Meckels that have any of these features. Length more than 2 cm, presence of the thickening indicative of presence of the ectopic mucosa, width of the Meckel diverticulum base, very wide diverticulum, indicating presence of the ectopic mucosa. In male children, remove the diverticulum, and if the age is less than 50 years. So these 5 criteria supposed by the third school to perform what's called selective approach. So the first school, no resection. The second school, resect. The third school, perform a selective approach. Yes, selective approach, meaning remove based on certain criteria. Look for the length, look for the thickness, look for the weights, look for the male, the gender of the patient, and the age. Okay, it's true. 3 options up till now. Other studies recommend resection regardless of the macroscopic find, as they found that and arguing that thickening and length and base are not always possible to clearly determine by inspection or palpation. So this criticism to the last one. The last one of the selective approach proposed that the pediatric surgeon should check for the Meckel characteristic, the length, the width, the base, the age of the child. However, some pediatric surgeon says that this is not practical for the pediatric surgeon to look for the characteristic and make a decision according to characteristic feature. So the thickening, length, and the base are not always possible to determine intraoperative. So give me a solution which is very easy, not depend on analysis of these criteria. So this recommend resection regardless of the macroscopic features. This school is the same as the first school recommend resection. So resection may be performed without any requirement for all detected Meckels. This is number 1. Number 2, some pediatric surgeon recommend no resection. Number 3, other pediatric surgeon recommend selective approach. Number 4, sometimes some pediatric surgeon says no selective approach. Remove all Meckel detected, incidentally detected Meckels, because the confirmation of the thickening, length, and the base are not always possible to be determined by inspection or palpation. Finally, Given the lack of the clear consensus about Meckel diverticulum incidentally found, the decision to resect an incidentally discovered Meckel should be based on the surgeon clinical judgment. So you can resect left the Meckel diverticulum. It's your decision, depend on your experience. It's your surgeon clinical judgment, because there is a lack of clear consensus. Yes, to summarize and to put the information at glance, symptomatic Meckel diverticulum, this is number one. Symptomatic means present with bleeding, perforation, obstructions, Meckel diverticulitis. There is no debate. This is the definitive treatment is surgical resection, whether open or laparoscopic. We can remove only the diverticulum, diverticulotomy, or we can perform segmental ileal resection with anastomosis. When to perform this and when to perform this? Removal of the diverticulum, patient with obstruction or inflammation, often sufficient if the pediatric surgeon are sure that all ectopic tissue is removed. In patient with intussusception, may be possible to remove only the diverticulum, depending on the appearance of the bowel. In patient with bleeding, several studies reported success with no episode of recurrent bleeding and shorter operative time and hospital stay regarding removal of the diverticulum only. Segmental area resection with anastomosis. Patient with intussusception, safer, depend on the bowel appearance. In patient with bleeding, it is the safest to ensure ulcer removal. So this is slide. Collect the management of symptomatic Meckel diverticulum. No debate about surgical resection. Open, laparoscopic. Remove the diverticulum or segmental ileal resection, according to the presentation of the child. Obstruction or inflammation, often sufficient if the pediatric surgeon are sure that all ectopic tissue removed. Intussusception, we have two options. Removal of the diverticulum may be possible. However, segmental ileal resection safer, depending on the bowel appearance. So pediatric surgeon may perform removal of the diverticulum only or segmental ileal resection if the case is intussusception due to Meckel diverticulum. Bleeding, maybe to remove the diverticulum, yes. Several studies reported success with no episodes of recurrent bleeding, shorter operative time and hospital stay. However, it is safest to perform segmental ileal resection with anastomosis. Very important slide. All pediatric surgeon and pediatrician must be aware of this and put this algorithm inside the clinic and inside the pediatric surgery and pediatric department for managing the symptomatic Meckel diverticulum. On the other hand, asymptomatic Meckel diverticulum found incidentally. This finding may be on imaging studies. Yes, in such case, operative intervention is not indicated on CT or ultrasound, or maybe intraoperative. Intraoperative, we have many schools. Number one, resection, remove the Meckel. Why? Because the risk of the future complications is very high than the risk of the Meckel, removal of the Meckel. Number two, no added morbidity or mortality when you perform removal of the Meckel. Number three, for fear of the tumors, especially in families with very high risk cancer history. Number two, second school, no resection, because the risk of the surgery and the unplanned removal of the diverticulum may carry high morbidity and mortality. They argue that no resection, don't remove the Meckel. Number three, perform selective approach. Depend on the Meckel's characteristics, length, thickening, pace, male gender, and age. However, finally, removal regardless of the macroscopic finding, the thickening and the pace and width not possible to determine by the inspection and palpation. Very important two slides for the management. Asymptomatic Meckel diverticulum found incidentally may be a problem facing pediatric surgery. What to do? Remove or not? 4 schools. Removal with arguing. No resection, selective approach, removal regardless of the macroscopic finding. Postoperative complication, early complication estimated about 10%, maybe anastomotic leakage, stricture, adhesion, and postoperative ileus, and late intestinal obstruction from adhesion. While minimally invasive surgery in children has great advances, one database study claimed to report no difference in the outcome in the patient with open versus minimally invasive for Meckel diverticulum. In conclusion, omphallomesenteric duct remnant are very important developmental lesion that may present at a variable presentation at any age range, thought most commonly will be encountered and managed by the pediatric surgeon. It's therefore the key that the surgeon are familiar with the case care pathway to perform successful management and outcome. Finally, this image is very important. This is the umbilicus, and this is the omphallomesenteric remnant or the vitelline duct attached to the Meckel diverticulum attaching to the ileum. Also, other structures may be attached to the umbilicus. There is maybe median umbilical ligament or the urachus. There is maybe medial umbilical arteries, and there is maybe round ligament or umbilical vein. Very important to understand that these structures, all these structures attached to the umbilicus. As we see, this image is very important. This is the ileum. This is the omphallomesenteric duct. Meckel diverticulum, the first part, or maybe omphallomesenteric fistula, if the complete patency, or maybe omphallomesenteric cyst. This is the round ligament attached to obliterated umbilical vein and the medial umbilical ligament, umbilical arteries, and the median umbilical ligament obliterated urachus, filial conclusion may lead to urachal anomalies. It's very important that round ligament represents the umbilical vein. The medial umbilical ligament represent the umbilical arteries. You can remember this with medial all umbilical arteries, and median, AN is represented an allantois or urachus, so you can remember it very easy. At the end of this presentation, it's very important to understand that omphallomesenteric duct remnant or omphallomesenteric or vitelline duct or vitellointestinal duct is very important. This duct, intrauterine duct connecting between the primitive yolk sac and the developing midgut, it functions as to allow for the growth and the elongation of the intestinal tract until the oropharyngeal and the cloacal membrane are opened. These ducts usually obliterate and close completely. However, they may present with remnant. This remnant may be Meckel diverticulum resistant of the intestinal segment of the duct, very common. Maybe fistula, complete patency of the duct, maybe fibrous cord, maybe cyst. Pediatric surgeon should be aware of this duct and the anomalies of it. Meckel diverticulum is a true diverticulum of the intestinal wall of the ileum. The problem in the Meckel is containing ectopic tissue, gastric tissue. This gastric tissue may lead to formation of an ulcer with a bleeding. Very important. Meckel may be present clinically, may be asymptomatic at all, present incidentally, or may present with gastrointestinal bleeding, bright red blood per rectum in a young child, may be painless and massive bleeding. May present with intestinal obstruction. Whether intussusception, this Meckel is inverted inside the lumen and act as a lead point, maybe volvulus, twist around band or kink, maybe internal hernia, maybe incarcerated letters hernia or giant diverticulum or long, maybe twist around its base. May present with acute diverticulitis similar to the acute appendicitis. You cannot differentiate clinically. However, by investigation, if you are lucky to find midline mass with the gut signatures, the true walls of the gut in the midline away from the site of the appendix. It's very important to understand the management of the Meckel diverticulum. How to manage. Symptomatic or asymptomatic? Symptomatic, no debate. We need to remove this Meckel diverticulum. However, the removal may be open, laparoscopic, and that the removal may include only the diverticulum. leaving the ileum, or segmental ileal resection. Whether to choose will depend on the presentation, obstruction or inflammation, bleeding case, or maybe related to the perforation or diverticulitis. So each one has advantage and disadvantage. The most important debate today is incidentally detected Meckel. Incidentally detected on imaging studies, no debate. No operative intervention is required. Incidentally detected intraoperative. The pediatric surgeon classified into different schools. Resection and arguing 1, 2, 3. Don't resect. Arguing 1, 2. And selective approach. Resect depending on 1, 2, 3, 4, 5 criteria. And the last school said that this selective approach is not applicable. We cannot perform and take a decision depending on criteria. It sometimes may be difficult, intraoperative by inspection or palpation. So they recommend remove, like the first school, regardless of the macroscopic presentation. So this is the schools for incidentally detected Meckel diverticulum found intraoperative. I think this presentation is very important. Don't forget the umbilicus, structures attached to the umbilicus, omphalomesenteric or vitelline duct, structures may be Meckel with a fibrous band, maybe complete fistula, maybe cyst. And don't forget the median umbilical ligament, the medial umbilical ligament, the patent urachus, and also, by the way, what's called lateral umbilical ligament, which is peritoneal fold overlying the inferior gastric vessels. These structures related to umbilicus will be very well and very obvious to the pediatric surgeon performing laparoscopy, seeing the posterior abdominal wall from it. It's very clear for all of us during this laparoscopic view in performing repair of different types of inguinal or femoral hernia. I think the topic is very important for all pediatric surgeons. The problem may be serious, maybe bleeding with undiagnosed cause. All pediatric surgeons should put Meckel as a differential diagnosis for a bleeding lower gastrointestinal tract in children, maybe similar to appendicitis, may lead to present with intestinal obstruction by different mechanisms. All pediatric surgeons must understand these variations of the omphalomesenteric duct anomalies and the Meckel diverticulum's association, and how to diagnose and how to manage, how to take a decision for incidentally detected intraoperative or imaging studies for symptomatic Meckel to perform just the removal of the diverticulum or resection and anastomosis. Thank you very much for watching this topic. I hope it will be very informative and very presentative for all pediatric surgeon and pediatrician, and see you later in next subject of pediatric surgery made easy. Thank you very much.